Welcome, I'm Don Renfrew, and for the next hour or so I'm going to be discussing gastrointestinal imaging. This is actually the second of two lectures that I give on gastrointestinal imaging, but I will review all the points that I made in the first lecture before I get to the additional points that I want to make in this lecture about gastrointestinal imaging. I'll be brief in those though, so if you really want the detail about the first lecture, go back and watch the first lecture, but I will review the contents of the first lecture. I'm a private practice radiologist. I practice with Radiology Associates of the Fox Valley. We are a group of about 30 radiologists covering 9 community hospitals in the upper central portion of Wisconsin. I do most of my work at this hospital, which is Door County Memorial Hospital in Sturgeon Bay, Wisconsin. Door County is a resort community, and it's actually in the thumb of Wisconsin's mitten, where you can see the little red star there. It's a community of about 9,000. There are about 25,000 people on the peninsula in the county, and on any given summer day there are 80 to 100,000 people in the county. So it's very much a resort area. It's surrounded by beautiful Green Bay on one side and beautiful Lake Michigan on the other side. It's actually quite nice. There's a 25-bed critical access facility hospital. It's at least 50 miles from the closest hospital. And I'm basically the only radiologist there, so I sort of wear a few hats in the hospital, one of which is the director of the radiology department, medical director of the radiology department, and another is head of grand rounds. And as head of grand rounds, I often present material to the referring clinicians. Associated with the hospital, there's a multi-specialty clinic where there are family physicians and nurse practitioners and physician's assistants that order exams. And as part of grand rounds, I frequently lecture these folks on what study to order. In the process of providing these lectures and this material, I've developed a set of lectures that have to do with what radiology study to order for different patient symptoms. And this lecture is basically one of those. Now, who's this lecture for? It is for primary care providers. Primary care providers typically, in times past, were thought of as being family medicine physicians, but in times to come, it'll probably be more nurse practitioners and physician's assistants. These are people that see patients and that order radiology studies, and I'm going to try to help you decide which study to order under what circumstances in radiology. Now, you have a lot of options for imaging the gastrointestinal system, and you're not even, limited by what you see here: gallbladder ultrasound, CT scans, endoscopic retrograde cholangiopancreatography, barium swallow, and nuclear medicine studies and MR. At the same time, you want to order the right study the first time every time, and what I'm here to do is to tell you how to go about doing that. Now, as I mentioned, I have another talk called First Step GI Imaging, and I'm going to briefly review the points that I make in First Step GI Imaging. And those points include that ultrasound is widely available, is of relatively low cost, and has no radiation. It is one of the first steps in imaging, and there are relatively few first steps in imaging, ultrasound being one of them. Another one is CT. CT is evolving, it's improving through time. The protocol is typically set by radiologists. The third modality is our fluoroscopy and plain film examination. Those techniques are actually losing ground to other modalities, particularly CT and ultrasound, but also endoscopy as time goes on. Another point from my other lecture is that ultrasound is the imaging study of choice for evaluating right upper quadrant pain and suspected pancreatitis. Ultrasound can show signs of gallstone disease. It'll show gallstones in the gallbladder. It can show a dilated duct, and it can show gallbladder wall thickening. Pancreatitis you can look at with either CT or ultrasound. The point of looking at it with ultrasound is to exclude gallstone pancreatitis, a reversible cause that can be surgically corrected, versus other causes of pancreatitis such as alcohol and drugs, etc., that don't require emergent surgery. Point number 3 of that other talk was that CT is the imaging study of choice for the evaluation of abdominal pain plus. Abdominal pain plus is helpful when you have abdominal pain plus features of inflammation, such as fever, an elevated white blood count, elevated erythrocyte sedimentation rate, or elevated C-reactive protein. And of course, the diagnosis you're looking for in patients with inflammation and abdominal pain. Statistically, it's one of three processes typically. Appendicitis, shown here with the arrow, an inflamed appendix, periappendiceal fat stranding, thick-walled appendix that's dilated. This is an example of diverticulitis, where you have a loop of sigmoid colon that has abnormal soft tissue adjacent to it, stranding in the fat, and probably an early abscess formation. And finally, a relatively rare entity, at least thought to be rare, we're seeing it more now that more of these people are getting imaged, called Appendagitis Epiploicae. And that's from torsion of the appendix along the colon, not the vermiform appendix, but the little fat-containing appendices along the colon wall. If they twist and and their vascular supply is obstructed, you can infarct a small portion of fat, but it produces symptoms of pain and often symptoms of inflammation as well. And CT can give you the diagnosis in those cases. CT is also helpful not only with inflammation, but with other scenarios of abdominal pain plus, like obstruction, mass, weight loss, and diarrhea. Finally, barium studies are helpful in the evaluation of swallowing difficulties. Typically, you're using swallowing studies to diagnose penetration and aspiration, and these studies are almost always done in conjunction with a speech pathologist to evaluate function in the hypopharyx. Esophageal swallows have, for evaluation of distal esophageal symptoms, have largely been supplanted by endoscopy. So again, that's first step GI imaging, relatively few studies. Gallbladder ultrasound and right upper quadrant ultrasound for right upper quadrant pain and suspected biliary colic, pancreatitis, CT for abdomen pain plus, video fluoroscopy for evaluation of swallowing difficulties, particularly oropharyngeal dysphagia, as opposed to esophageal or distal dysphagia. What happens when the first step isn't enough? Well, you go on to step number 2, which is now in color and 3D. Second step, GI imaging. What are my points in this lecture? My points in this lecture are that there are 4 points that I wish to make. The first of which is that women with low abdomen and pelvic pain may need both CT and ultrasound for evaluation. You may need more than ultrasound for the evaluation of right upper quadrant pain and suspected biliary disease, especially if there are abnormal enzyme studies. You may need small bowel imaging with additional evaluation after a standard CT study. And finally, CT can discover incidental lesions, or sometimes it's performed in asymptomatic patients. And I'll kind of cover these topics today. So the first topic is women with low abdomen and pelvic pain may need both CT and ultrasound for diagnosis. Because of the proximity of the bowel, bladder, uterus, ovaries, and fallopian tubes, many processes result in low abdomen and pelvic pain in women. Often women will have either an ambiguous or frankly misleading signs and symptoms because of the proximity of disease processes, and diagnosis can be elusive without performing either CT or ultrasound or both. Now, you want to do CT for bowel abnormalities. If your primary suspicion is for a bowel-related abnormality, CT is going to be your study of choice, especially if there's features of inflammation or obstruction, as I talked about in CT before. CT is performed for diverticulitis, appendicitis, Appendagitis Epiploicae, and colitis. If the CT is negative, ultrasound can provide an explanation of symptoms. Here's a case of appendicitis where you really don't need to do an ultrasound exam. Now, for lesions discovered at CT, sometimes you'll add the ultrasound to further characterize those. Sometimes you do an ultrasound because CT is either negative or ambiguous. Let's look at a case. Here's an 86-year-old with abdominal pain and a possible palpable mass. She'd been feeling feeling ill, and she went to her family physician, who felt that there might be a palpable mass of the abdomen. The CT study showed a large amount of feces, probably accounting for the palpable abnormality at the location of these arrows. The white arrows are where the palpable lumps of feces are in the sigmoid colon. The blue arrow indicates an adnexal lesion at where the blue arrow is here. Now we did ultrasound, and on the ultrasound study, what you see is a cyst where the white arrows are, measuring less than 50 millimeters, and it has a thin septum where the blue arrow is. Since the patient was not having any pain or other symptoms from this apparent benign cyst, and since the lesion measured less than 50 millimeters, it was elected to follow the lesion, so the lesion actually measured a little less than 50 millimeters. This may seem like a waste of time and energy, but further evaluation of such pelvic lesions may sometimes alter the clinical course of events. Here's a 51-year-old that came into the ER for pain and fever, and this CT was done, as you can see, on 12/8 of 07. The impression on this exam included the following. There's no definite cause of the patient's abdominal pain and fever seen on the current study. Again, seen as a myomatous uterus as well as bilateral cystic adnexal lesions. However, a solid component of the right adnexal lesion more superiorly has increased in size. This is somewhat concerning and warrants further evaluation with either ultrasound or CT scan of the pelvis or on IV contrast. So this patient came in with pain and fever and the CT done. Now here's an earlier study, and this was what the radiologist was talking about. So the new study where the white arrows is, it's kind of a cystic lesion. White arrows on the old study, cystic lesion again. The contralateral blue arrow shows a cystic lesion on the other side, which is actually decreased. So the prior study, which is an even earlier study, was available way back in 01, and it had been performed for trauma, and it noted numerous cysts, presumably within the ovaries were noted, and the largest was on the right and measured 6 millimeters. Now, none of these other studies actually advised going ahead with ultrasound, but you can see there's kind of a change in appearance of the CT. And remember, the patient came to the ER for fever. She subsequently went to a gynecologist who looked at all this and said, well, she didn't get an ultrasound to figure out this adnexal lesion. So here's the ultrasound study, and you can see this big tadpole-looking thing here with arrows along where the tail of the tadpole is. Note the serpentine appearance of this hypoechoic region. It shows a gradual increase in caliber along with some internal echoes. This appearance is classic for hydrosalpinx, and the internal echoes suggest a superimposed infection or pyosalpinx, particularly considering the patient's clinical history, which included fever. So the diagnosis on the ultrasound was hydro versus pyosalpinx, and the patient was treated with antibiotics. Subsequently underwent surgery and had a tubovarian abscess and pyosalpinx. So here's a composite of the CT and the ultrasound, and this shows you that the ultrasound actually added considerable detail to the image in the workup done by CT. All right, so this demonstrates that additional advantage of the ultrasound. Now, ultrasound you do for ultrasound you do when you suspect there's uterus and ovarian abnormalities, and then you add the CT to that if you need it. We've just seen 2 cases where CT demonstrated a pelvic abnormality and then you did ultrasound, and that works pretty good. The converse is also occasionally true. If your primary suspicion is for an abnormality of the uterus or ovary, ultrasound is going to be your study of choice. Ultrasound is performed to evaluate ovarian torsion and adnexal masses, uterine fibroids, ectopic pregnancy, and other disorders that may present with either low abdominal pain or a pelvic mass. There are occasions where ultrasound will discover a lesion, or sometimes it will be negative, and CT is helpful in further evaluation. Here's a 40-year-old woman with lower abdomen pain and a pelvic or low abdomen mass. The transabdominal ultrasound demonstrated a pretty normal appearing uterus, shown here between the arrows, so that's not a problem. Here's an ultrasound performed somewhat higher in the abdomen, and this shows a large, smoothly marginated mass, noted here by the arrows. So what's going on here? It was very unclear what the heck was the cause of this lesion, and in this circumstance, this is where a CT can help out. Here's a CT scan that shows this lesion, and on the sagittal image, note that the lesion is actually separate and superior to the uterus and anterior to the lumbar spine. An axial cut's shown here. Here's your lesion with arrows on it, and Any thoughts about what that might be? I mean, it looks like a large solid mass, independent of the uterus. Well, a CT biopsy was performed. Here you can see the arrow in the mass, and there's an arrow, you can see the needle, the biopsy needle in the mass, and here's an arrow marking the needle tip. The tissue was typical of leiomyoma. The patient subsequently underwent a surgical resection, and the lesion was a benign extrauterine leiomyoma. Remember, on the sagittal CT cuts, it was actually separate from the uterus. This is a case where CT added additional information and helped out. Now, there's another kind of entity called, I think of them as lining abnormalities or abnormalities of the mucosal surfaces of pelvic organs. They can be very difficult to visualize. They sometimes require multiple imaging modalities before you can make a diagnosis. And many times these entities can produce symptoms which are characteristic on clinical evaluation and don't really require imaging, but sometimes imaging is necessary. Now, the mucosal surfaces we're talking about here include the bladder mucosa, large bowel mucosa, and uterine mucosa. Now, here's a 79-year-old with clinical features of cystitis. While this patient did have clinical features of cystitis, including frequent voiding and some pain with urination, the clinician, who's a smart guy, realized that the symptoms were more likely related to bowel than bladder. He ordered a CT study, and that confirmed diverticulitis and an abscess adjacent to the bladder. This is an excellent case illustrating why some patients with clinical features of cystitis actually have diverticulitis. Note that the patients may also have pyuria and hematuria. That'll even further confuse the situation. Here's a patient with abdominal pain and extensive diarrhea who had had antibiotic treatment for colitis, for H. pylori, and developed pseudomembranous colitis. Here the white arrow is on the inflamed colon, and the blue arrow is on inflammatory fluid in the cul-de-sac. This is a case where the lining abnormality is in the colon. Either the clinical history or the CT or endoscopy would likely point in the right direction in this case, without usually resorting to multiple imaging modalities. Here's a 32-year-old patient with pelvic pain in the mass on an ultrasound exam. And this brings me to other lining abnormalities. And this lining, in this case, is the endometrium. In endometriosis, which is ectopic endometrial tissue outside the uterus, that can cause pain in the abdomen and be challenging to diagnose with either ultrasound or CT. It may simply show a nondescript soft tissue mass or masses. MR can assist sometimes in making a diagnosis because it can detect blood breakdown products. In endometritis, which is inflammation of the uterine lining, ultrasound can be normal, or sometimes it just demonstrates a thickened endometrial stripe and air bubbles if it's a gas-producing organism. In adenomyosis, the endometrial lining invades the myometrium, and that leads to a thick uterine stripe on ultrasound and a relatively characteristic MR appearance with multiple tiny cystic cavities within the myometrium. So, to recapitulate, women with low abdomen and pelvic pain may need both CT and ultrasound for diagnosis. That leads us to point number 2, which is that more than ultrasound may be necessary for the evaluation of right upper quadrant pain. While ultrasound is the first step for biliary colic and pancreatitis, as noted before, there are occasions when evaluation won't stop with ultrasound, and where ultrasound is either negative or sometimes not. Further evaluation may then be directed by either the pattern of enzyme abnormalities of the patient symptoms, or abnormalities seen on the ultrasound exam. So let's talk about liver enzyme abnormalities first. Now, a lot of times the patients will come to the ultrasound department or radiology with the clinical history of abnormal LFTs or abnormal liver function tests. Sometimes CT will be requested for the same reason. Now, purists are going to say that abnormal LFTs is probably not quite technically correct, because LFT means liver function tests. And that might be the wrong term, really, to talk about aminotransferases, which are more properly called liver damage enzymes. So liver function tests for the purists can refer to synthetic functions such as serum albumin or prothrombin. But from a radiologist's perspective, the distinction between the function and damage issue is probably not as important as the pattern of enzyme abnormality. That can provide at least a clue as to the diagnosis when you've got a patient with abnormal LFTs. An important point to remember is that the radiologist may not have access to all the exact lab values when interpreting the study, and therefore it makes sense for you as a clinician to tell the radiologist what the pattern is. So what are the patterns? Well, there's the hepatocellular injury pattern, as seen in this case of a 55-year-old woman with elevated transaminases and right upper quadrant pain. Hepatocellular abnormalities typically manifest as disproportionate elevations of aminotransferases compared to alkaline phosphatase. So there are multiple disease processes that can cause hepatocellular injury. Many of these demonstrate either no imaging abnormality or a non-specific abnormality, at least in the label, of course. Statistically, abnormal aminotransferases, especially if the elevation is mild, are going to have either no liver disease found, or they'll have hepatitis, alcoholic liver disease, or non-alcoholic steatohepatitis, or NASH. While an ultrasound study may show a fatty liver, the imaging study can't really distinguish between asymptomatic steatohepatitis and, steatosis and NASH, which is an inflammation. So note that the ultrasound, while it's less expensive, isn't really as accurate in evaluation of the fatty liver as MR or CT. Now, the ratio between AST and ALT can help in distinguishing NASH and alcoholic hepatitis. In general, the AST-ALT ratio is less than 1 in NASH, or non-alcoholic steatohepatitis, greater than 1 in alcoholic hepatitis. Now, the hepatocellular pattern of enzyme abnormalities, the imaging, expected imaging finding is going to be normal or a fatty liver. And with either normal or a fatty liver, you really need to kind of exclude hepatitis with serum screening. You have to figure out whether the patient's abusing alcohol or other drugs, and you're probably going to have to follow these patients. At least in some cases, you're going to end up doing a liver biopsy to establish the diagnosis. And you should probably consider that in cases where there's persistent twofold elevation of aminotransferases. Those are current recommendations. Of course, there are non-hepatic causes of elevated aminotransferases like muscle disorders, thyroid disorders, celiac disease, adrenal insufficiency, and anorexia. Now here's a fatty liver on a non-enhanced CT scan, and this demonstrates again that CT is capable of diagnosing fatty liver and also capable of finding fatty liver with more sensitivity than ultrasound. Now, what's the cholestatic pattern? The cholestatic pattern, again, is when the alkaline phosphatase level elevation exceeds the aminotransferase level. And now, in the cholestatic pattern, you've got a different set of diseases. You've got partial bowel duct obstruction, primary biliary cirrhosis, primary sclerosing cholangitis, and drugs, especially anabolic steroids, and also unsuspected metastatic disease. In patients with this pattern, as with all patients with suspected hepatobiliary issues, the first study is going to be an ultrasound, and that's going to evaluate for diffuse metastatic disease or biliary distension. If the ultrasound shows a diffuse liver abnormality, you're usually, or multiple focal abnormalities, either one, you're going to usually do a liver biopsy. In this case, this is a composite image of the ultrasound, the CT, both of which showed multiple widespread liver abnormalities in this patient. The CT also included the chest, and there's a large mass in the chest. The biopsy was done, and it was metastatic lung cancer that caused this pattern of abnormality. Note that this patient came in with a cholestatic pattern of abnormal liver enzymes, and not because she was coughing up blood or had any pain, weight loss, or other symptoms. So in this case, the ultrasound actually led you down the path for the correct diagnosis. Not a good diagnosis, but the correct diagnosis. What else about the cholestatic pattern? Well, if ultrasound demonstrates biliary distension, the patient's said to have extrahepatic cholestasis, unlike our cancer patient here who had hepatic cholestasis. So in that case, you're usually going to do endoscopic retrograde cholangiopancreatography, or ERCP. And that's going to be able to cause the diagnosis. It's often choledocholithiasis, or a stone in the biliary tree, and at the same time provide treatment, either stone removal or stent placement, if there's a tumor there causing the obstruction. In some patients, MRCP, or magnetic resonance imaging pancreatography, can represent an alternative to ERCP. For example, if there's a low likelihood that you're going to do an intervention. Note that this is an evolving area. your local availability of ERCP and MRCP are going to vary. So you probably want to discuss this issue with the local radiologist and surgeons and gastroenterologist in those patients with a extrahepatic cholestatic pattern on ultrasound and lab values, and try to figure out what the next step is, ERCP, MRCP, whatever. Okay, so now that kind of takes us through the abnormal liver enzymes and what kind of imaging to order on the basis of that. There's also those patients who have suspected biliary pain and a normal or ambiguous ultrasound, and normal or ambiguous enzyme results. In these patients, if they have suspected biliary colic, you're of course going to do biliary ultrasound first. And in many cases, it can be definitive. It may either be definitively positive, showing you gallstones and features of inflammation like pericholecystic fluid or sonographic Murphy sign, or it can be negative, definitively negative, where your suspicion of acute cholecystitis was actually pretty low. The negative ultrasound supported an alternative diagnosis like gastritis, and you're done. But there are patients where the clinical suspicion for hepatobiliary disease is high, and the ultrasound study is either going to be normal or ambiguous. In that case, further imaging can be helpful. Now, the pattern of enzyme abnormalities, if the patient has both enzyme abnormalities and biliary pain, can help direct your search to the, so if you got the cholestatic pattern again, you're going to need ERCP or MRCP. The hepatocellular pattern, probably going to do a biopsy. But there are those cases, again, where everything, all that stuff ends up being ambiguous, and you're thinking the patient may have biliary pain, and you need another test. This is the other test. And this is a 79-year-old man who had equivocal right upper quadrant pain. Was eventually, he did have gallstones, but it wasn't quite clear whether his gallstones were the cause of his pain or not. Now, the nuclear medicine study that we're going to talk about typically has two phases, but a lot of times, as in this case, only the first phase is necessary. In the first phase, the patient's injected with IV radioactive immunodiacetic acid. And so this is called a HIDA or DeCida scan. And the liver conjugates and secretes that stuff in the bile. Then sequential imaging should demonstrate the liver, the biliary tree, gallbladder, and the small bowel, sort of in that order. Patients with acute biliary pain and no gallstones, or where you've got equivocal features like this case, if you have that and you don't visualize the gallbladder within an hour, then really you're thinking in terms of acute cholecystitis. If the patient's really quite ill, then you're usually going to terminate the test and take the patient to surgery at that time. Now, this patient showed visualization of the liver, the biliary tree, and the small bowel, but not the gallbladder on the 1-hour study. He wasn't direly ill, and in this case, you usually continue the study. On this delayed exam, there's still no visualization of the gallbladder. That thing at the arrow is actually the duodenum, not the gallbladder. At this point, they took him to the operating room, and they did find cholelithiasis, which they knew about, but also cholecystitis, with a stone blocking the cystic duct. That's the reason why the gallbladder doesn't show up, is the immunodiacetic acid, which is conjugated to the bile, can't get into the gallbladder. It can go through the biliary system into the bowel, but not into the gallbladder. Okay, so if you don't have a real sick patient, you just keep imaging until you get out to the 4-hour or so mark. And if you never see the gallbladder, you probably have a case of chronic cholecystitis on your hands. If you see it somewhere between, if you never see the gallbladder, you still make the diagnosis of acute cholecystitis. If you see it between 1 and 4 hours, then you usually make the diagnosis of chronic cholecystitis. But there's some kind of cholecystitis going on if you can't see the gallbladder in this study. Now, in a lot of these cases, these patients are going to be suspected of having either acalculous cholecystitis or sphincter of Oddi dysfunction. And the clinical features of patients with sphincter of Oddi dysfunction can include epigastric or right upper quadrant pain. Sometimes they'll have elevated aminotransferases. Sometimes they'll have elevated bilirubin. Sometimes they'll have elevated pancreatic enzymes, and sometimes pancreatic type pain. The sphincter of Oddi dysfunction has a lot of synonyms, and those include papillary stenosis, sclerosing papillitis, biliary spasm, and biliary dyskinesia. And usually when you have a lot of terms applying to the same disease process, there's confusion about what constitutes the condition, what causes the abnormality, and how to diagnose and treat the disease. So with respect to the nuclear medicine study, the second phase of the study is trying to provide some information regarding hepatobiliary function. The patient's injected with cholecystokinin, which is a naturally occurring endogenous peptide that provokes gallbladder contraction. and then the patient's imaged for up to about an hour. Exact protocols will differ, and at least in our nuclear medicine department, an ejection fraction greater than 40% is okay. A lower ejection fraction is compatible with gallbladder dyskinesia. Patient's probably a candidate for cholecystectomy. Here's a 50-year-old man who had chronic right upper quadrant pain with normal enzymes, and all of his gallbladder ultrasounds, including this one, had been read as normal. He had his right upper quadrant pain was with fatty foods. There wasn't any gallbladder wall thickening. On his ultrasound study, he had visualization of his gallbladder promptly, but upon injection of the cholecystectomy, he has a severely diminished ejection fraction, 10%, well below our cutoff of 40% for normal, and this is a finding compatible with biliary dyskinesia. The patient had a cholecystectomy, and the pathologic diagnosis was chronic cholecystitis. The patient did get relief of symptoms with his cholecystectomy. Another issue is troubleshooting abnormal ultrasound studies and making sure that the gallbladder isn't the culprit if you see an abnormal ultrasound of the gallbladder. For example, in this 61-year-old woman, she had a focal gallbladder abnormality on her ultrasound. She had normal enzymes, by the way, but she did have this focal abnormality here, marked by the arrows, focal abnormality of the gallbladder wall. So what to do? This was suspected to be adenomyomatosis of the gallbladder wall, and it's a benign and it's usually an asymptomatic abnormality. So in this case, she did undergo a nuclear medicine study, prompt visualization of the gallbladder, as well as the liver biliary tree and small bowel, just like you'd expect with a normal study. Cholecystectomy injection resulted in 97% ejection fraction, very nice, absolutely normal study. So the patient, this would confirm probably a normal gallbladder, and subsequent endoscopy showed that the patient had gastritis and Brunner gland hyperplasia. She responded to treatment for those processes found at endoscopy, and the gallbladder abnormality seen on the ultrasound was probably an incidental finding. And the nuclear medicine study helped put at rest any issues about biliary dyskinesia. Another instance where you can see a role for additional imaging is when you do an ultrasound for suspected biliary disease, and then you actually see an ultrasound abnormality that isn't completely classic for either gallstone disease or some other straightforward diagnosis. So when you have a patient with pancreatitis that you see on the ultrasound exam, sometimes you'll do CT to figure out whether there's a draining abscess. Also, as we noted before, there's that case where you got abnormal liver on the ultrasound study, which was done for abnormal LFTs, and we did CT and found liver mets, did a CT-directed biopsy. In addition to those processes, a right upper quadrant ultrasound also will evaluate the kidney. And sometimes you see a surprise like this one, 57-year-old woman with right upper quadrant pain. The arrow is on the distended collecting system in her right kidney. On this slide, the kidney is labeled A, and that's a distended collecting system. B is a CT study filmed at a urogram window showing a distended collecting system on her right side. And you can kind of appreciate the degree of distension on both of these studies. The dilated collecting system can sometimes mimic multiple cysts on ultrasound, but with real time or with multiple images, you can get all those cysts to kind of join together to the renal pelvis, and you actually see a dilated renal pelvis. In this particular case, the urologist ordered a nuclear medicine study which confirmed significant differential function and a time activity curve on the right, diagnostic of chronic UPJ obstruction. The patient underwent pyeloplasty to remedy the obstruction, and that relieved her pain. So here's a case where ultrasound showed you something that you needed further workup for with other imaging modalities. Most of the time, by the time you get to that point, the radiologist is going to sit down or call you or talk to you about what your options are in terms of those further images. Okay. So that kind of covers the basis in when more than ultrasound is necessary to evaluate right upper quadrant pain. The next point I want to make in this talk is that small bowel imaging may require additional evaluation after the standard study. And why is that? Well, the first step in small bowel imaging typically isn't standard CT as far as imaging goes. Most small bowel abnormalities can be diagnosed with CT, will be seen on a routine CT study. Those studies can show bowel wall thickening. It's not a specific finding. It can be seen in a number of diseases, including Crohn's disease and hemorrhage from anticoagulation, for example, or infiltration of tumor cells like a lymphoma. Here's a 24-year-old who had acute abdominal pain and bloody diarrhea. The eventual diagnosis was Crohn's disease. Crohn's disease is one of the most frequent indications for a dedicated small bowel study. In Crohn's disease, in addition to the diagnostic initial study, you may do a follow-up study with low-density contrast. That allows evaluation of the bowel wall because you can't see bowel wall enhancement very well when you've got positive contrast in the middle. Again, this is a case where you can add a low-density contrast, either a specific commercially available product or even whole milk. And what you're looking for is the presence, severity, and extent of the disease, and then also to see if there's any extraintestinal complications, fistula, abscess, and so forth like that. So this is a CT done with an alternative contrast, and you can see that this is the exam on the left shows positive contrast in most of the small bowel and then some bowel without any contrast in it. The exam on the right is one done with a low density contrast through the small bowel, and you can see the bowel wall quite a bit better on that study. So usually this dedicated small bowel study stuff is only done after you've established a diagnosis, either because of a clinical history or endoscopy or a standard CT. So this is really kind of a second step in the sense of you're only doing this after you've got the patient's diagnosis established. Sometimes you do it when the patient returns with an exacerbation of symptoms. You've already got the diagnosis and you just want to kind of gauge the extent of disease. So again, the low density contrast lets you see the bowel wall quite a bit better. What is CT enterocolitis? Well, oral low density contrast, just administer orally by mouth, 1,500 cc's or so of it, either the whole milk or the commercially available product. That's the easy way to do this study. There's a hard way to do it, which is it's adapted from a fluoroscopic plain film technique called enterocolitis, which literally means bowel washing. In enterocolitis, you put a tube in the small bowel, nasogastric or gastric tube, put it all the way down into the small bowel. Because that's somewhat interventional, not every department will do that. In consultation with your radiology department is probably in order before you order enterocolitis. Enterocolitis can be done, it usually requires an administration of a large volume over a short period. Many departments use a pump to achieve that goal. And there are descriptions in the literature, and again, this is not a real widely used technique, but there's descriptions in the literature of enterocolitis, either plain film or CT. So you use a low density material, you put the tube down, usually in fluoroscopic guidance, take the patient with the CT scanner, flood the bowel with low density contrast and take a bunch of pictures. It results in a beautiful exam. Can show you areas of complication of inflammatory bowel disease, also can show you the exact point of stricture or narrowing. What about a small bowel follow-through? Some people use these with a positive higher density contrast material, although in most cases this study has gotten supplanted by either regular old CT or CT with a low density contrast or enterocolitis. Capsule endoscopy is another alternative. It's the wireless video capsule endoscopy involves swallowing a disposable 11 by 26 millimeter capsule. It's got a camera in it that transmits pictures to receivers that are on the patient, and that can be used to evaluate the small bowel. It takes thousands of pictures, and it's kind of tedious to look at all those pictures. But one issue to think about here is it is one of the only ways to look at the small bowel. I mean, it's hard to look at the small bowel. The esophagus, stomach, proximal small bowel you can look at from above. The colon you can look at from below with optical endoscopy. But it's hard to see the small bowel, the surface of it optically, unless you're using something like capsule endoscopy. The other thing about capsule endoscopy, it is 11 by 26 millimeters, and that means you can't give it to somebody with a bowel stricture. So typically, have to exclude high-grade bowel stenosis before you give them that capsule, and you're often going to have to do CT or something of that nature to do that. There is another second step for evaluation of bowel obstruction, and that's sequential plain films following gastrographin. There are some studies that suggest that orally administered gastrographin can not only document small bowel obstruction, it also can energize the bowel and resolve partial obstructions. This is a 68-year-old who had persistent distension and vomiting following a colectomy, and this arrow shows a transition point in her small bowel where she actually tapered down. It's probably an adhesion of some variety. She was given the gastrographin, and some of that got through to the large bowel, as you can see on this picture. Nonetheless, she continued to not do well, and as you can also see on this picture, there's quite a bit of gastrographin left in the stomach and small bowel, distended small bowel. She was taken back to surgery. The adhesion was lysed, and she did much better. So that's small bowel imaging, and again, small bowel imaging is another step past your standard evaluation. A number of different ways to image the small bowel, and all of them usually are going to require consultation with your radiologist, gastroenterologist, and gastrointestinal surgeon before you make the decision as exactly which of those different exams to use. But I'm just kind of trying to give you an overview. Okay, so that leaves us a few minutes here to talk about incidental lesions or those discovered in asymptomatic patients. Now, the extended and expanded use of imaging through time, particularly CT scanning, has created a new class of lesion, and the term incidentaloma refers predominantly to lesions of the adrenal that are found when scanning a patient, and I'm going to talk about those lesions first. But the term also applies to other incidentally discovered lesions that aren't really related to the reason you got the exam. Most commonly, you're going to see them in the adrenal, which I'm going to talk about first. The liver, I'll talk about here. And lung, I'll talk about incidentally seeing pulmonary nodules in another lecture. Which kind of leads me to the subject of whole body screening CT. Now, one of the things to keep in mind when you're dealing with incidentally discovered lesions is that the CT functions as kind of a screening tool for whatever body part is scanned. And indeed, many entrepreneurs have opened up centers for CT screening to evaluate asymptomatic or basically asymptomatic patients that and they're looking for occult but significant disease. This practice has engendered a lot of interest on the part of the press and the lay public, but it's not approved by the FDA. What the FDA says about it is this, quote, "The FDA has never approved CT screening of any part of the body for any specific disease, let alone screening the whole body when there are no specific symptoms for disease at all. No manufacturer submitted data to the FDA to support the safety and efficacy of screening claims for whole body CT screening." Now, whole body CT screening, there's a full review of this is really beyond the scope of what I'm talking about here. But there's a spectrum of opinion about this, and I come down close to the end of the spectrum of why are we doing this? And my opinion is informed in part by this excellent book by Welch, which talks about screening studies, cancer screening. The book notes it's difficult to show efficacy of a screening study. It's very difficult, and especially screening with imaging. There's even controversy, as it notes in this book, about widely accepted screening studies like mammography and PSA. These issues are good to keep in mind when you're dealing with incidentally found lesions, because even if the lesions are malignant, they may represent what Welch and others call pseudo-disease, which are cancers that will never matter to the patient. What does it say in UpToDate, that excellent online resource with current information about screening studies? Here's the problem, as it says in this article in UpToDate. Quote, "Primary providers who may not have ordered or discussed the study with the patient, the CT screening study with the patient before it was done." In other words, the patient decides he wants a CT screening, goes to an outpatient imaging center, puts his money on the counter, gets a CT screening, then comes to the family doc and says, family providers who may not have ordered or discussed the study with the patient before it was done are expected by the patient to provide management recommendations and education without clear supporting evidence, and that's the problem, or at least one problem. So I'm going to try to help a little bit about some of these issues, one of which is adrenal incidentalomas. There's kind of two sets of considerations with adrenal incidentalomas: clinical issues and imaging issues. Now, adrenal incidentalomas are by definition lesions larger than a centimeter. They're incidentally discovered on an abdominal CT study performed for reasons other than investigation of possible adrenal abnormality. In other words, these patients aren't coming in because they have a known primary looking for adrenal mets or abnormal enzymes related to their adrenals. So there's these two sets of images, the clinical set and two sets of issues, clinical and imaging. From your clinical standpoint, patients with incidentalomas, even small and definitely benign ones, which are going to be most of them, they still need to undergo endocrine evaluation. Why is that? Well, some of these incidentalomas will actually be functioning even though the symptoms are mild enough to escape detection by the patient and the clinician. The common tumor types determine the symptoms and the laboratory abnormalities. But since the tumor type's unknown before you do your investigation and evaluation, it's usually necessary to screen for all three possibilities: cortisol producing, adrenaline producing or pheochromocytomas, and aldosterone producing. The cortisol producing tumors can produce subclinical or clinical Cushing's disease, and they can be associated with obesity, hypertension, glucose intolerance, or diabetes or hypercholesterolemia. It sounds like metabolic syndrome, basically. The pheochromocytoma can produce paroxysmal hypertension or flushing and anxiety. Aldosterones can produce hypertension from sodium retention, and so your recommended laboratory test would include a dexamethasone suppression test looking for Cushing's, a 24-hour catecholamine test for pheochromocytomas, an evaluation of serum sodium, and if there's hypertension, measurement of serum renin and aldosterone for suspected aldosteronemia. So that means that all these patients with incidentalomas on their CT scan, and this is what the endocrinologists recommend doing, they take them through all these tests to see if these incidentally discovered tumors of the adrenal glands are actually something other than a benign non-secreting adenoma. So you do all those tests to figure out that part out. And if any of these turn out to have clinical hormonal significance, if they're secreting tumors, then definitely endocrinology involvement and therapy is necessary. So that's the imaging part. What about that's the clinical the clinical part and the hormone part. Now what about the imaging part? What are the imaging issues? Here's a table, and basically radiologists are going to differ somewhat in their recommendations as to which additional tests to perform. In general, the patient's going to probably have to return to the radiology department, either for an unenhanced and then possibly a delayed enhanced CT. Usually you find these things on enhanced CTs, and you need the unenhanced to figure out what the density of the adrenal is to characterize it. And you can also, instead of doing the CT, some people like doing an MR. CT is cheaper, more available, and with the washout tests, which are based on contrast clearance and Hounsfield units measurements, they're very effective in differentiating benign and malignant causes. You're doing these tests to figure out how big the adrenal mass is and what the fat content is. And then in addition, after you've established that the lesion is, say, 2 centimeters or whatever, and is benign and doesn't have any secreting abnormalities, usually the recommendations are to continue to monitor these patients on an ongoing basis, because any increase in size of an adrenal lesion is grounds for removal. So if somebody gets an adrenal incidentaloma, it's kind of a pain, because you got to do all these laboratory evaluations, you have to bring them back for further imaging, and they're usually subject to follow-up, so it's kind of a big deal. Let's look at a couple of quick examples. Here's a 60-year-old woman with hematuria, and in this case, there was an axial CT done during the nephrogenic phase of a CT performed for hematuria, and it showed a mass in the right adrenal. The non-contrast study performed at the same level showed the adrenal lesion to be hypodense, Hounsfield units of less than 0. That establishes the diagnosis of a benign adenoma. It still can be secreting, but it's a benign adenoma. What about this case? Here's a 78-year-old man with esophageal carcinoma, and he had a lump. And the image on the left, the CT was done for workup for the esophageal cancer, and of course you have an adrenal lump and any malignancy, you're thinking it could be a MAP. Fortunately, this guy had an image study on the right, which was done 8 years earlier. The lesion had undergone no interval change, and in this case you are done, because you've got all the follow-up you need on this particular case, and it's a benign adrenal adenoma. All right, that brings me to the last imaging topic I'm going to discuss today, which is virtual colonoscopy. Now, this technique involves a large bowel prep, and then, and people give hour-long talks, of course, on this topic, but just briefly, you do pretty much a full large bowel prep, and then you put a catheter in the rectum and you insufflate air. Sometimes people will also take some material that will tag feces with barium or radiodensity marker. There's dedicated software that processes and post-processes all the image data, and then you can get the standard axial, coronal, sagittary formatted images, but also a fly-through, and it's colored and it looks like the colon, and the images that it can produce are really quite impressive. Having said all that, at least for me, it's hard for me to make any sweeping statements about when to order or use virtual colonoscopy. Now, advocates are going to note a lower perforation rate than optical colonoscopy, and also the fact that optical colonoscopy can miss some lesions hidden behind bowel folds, and you don't really need sedation. You don't absolutely have to have sedation for optical colonoscopy, but it sure helps. But for virtual colonoscopy, you don't really need sedation. Now, on the other hand, the people that like optical colonoscopy will say optical colonoscopy is the reference standard at this point for polyp and cancer detection, and that you can remove polyps at the same time you're doing optical colonoscopy, but you can't do that with virtual colonoscopy. Most patients prefer optical colonoscopy, at least in some studies, maybe because they're sedated. At any rate, one very important point is that right now the CMS, or Center for Medicaid and Medicare Services, they don't cover virtual colonoscopy, and a lot of the insurance companies follow their lead. So, whether to recommend virtual colonoscopy as an alternative to optical, it's a controversial and evolving question, and the best thing I can tell you is you got to take into account your patient preference, the local expertise, the insurance company stipulations, and then you kind of go over with the patient what the pros and cons are. So that's virtual colonoscopy from my perspective. So I've just gone through what happens when the first step isn't enough. You go to the second step. And what are the second steps? Again, to reiterate, women with low abdomen and pelvic pain may need both CT and ultrasound for evaluation of their problem. Again, the CT you want to do first if you're thinking it's the bowel, and the ultrasound first if you're thinking it's the uterus or ovaries. But you may end up having to do both of them. For right upper quadrant pain, more than ultrasound sometimes is necessary to evaluate right upper quadrant pain and suspected biliary disease, especially when there's abnormal enzyme studies. But again, enzyme studies will show you either hepatocellular damage or cholestatic pattern, and that will kind of determine what further imaging you do. Ultrasound can also show you unsuspected or kind of unusual surprises like renal distension, as we covered in that one case. Small bowel imaging, again, most of your small bowel abnormalities are going to be diagnosed on a clinical evaluation or a standard CT study, but after you get those studies, you may need additional small bowel study, either with a low density contrast and a CT scan, enterolysis, sometimes small bowel follow-through studies. Gastrografin studies can be used in those patients with ileus or a low-grade obstruction in certain circumstances. Finally, CT can discover incidental lesions. Classically incidentaloma referred to adrenal lesions discovered in this fashion, over a centimeter. And again, two issues with those. Endocrine, they need kind of pretty much a full-bore endocrine workup looking for any possible actual function in the lesion, and then an imaging workup to determine whether it's more likely malignant, more likely benign, and often those patients end up having a follow-up Other incidentally discovered lesions like those of the liver may require additional imaging, either with another CT scan or an MR scan or an ultrasound to further characterize the liver lesion, sometimes biopsy. And finally, virtual colonoscopy, kind of an evolving, ongoing area. It may at one point supplant optical colonoscopy. It does offer some cost advantages, but right now CMS and a lot of the other insurers aren't paying for it, and it does have some disadvantages as well. And in some instances, there's a hybrid system where people come for virtual colonoscopy, are given a pager. If that's abnormal, they immediately go on for optical colonoscopy. And there are models that suggest that may have some advantages in cost, patient compliance, and bring more people in for screening for colon polyps. And what you're basically looking for is to catch polyps before they get big enough to cause cancer and metastatic disease and so forth. So that's the talk on second step GI imaging. Thank you very much.